Chapter 25, Fluid Balance, Screencast 5. Now, this screencast will be focusing on primarily electrolytes, but the first thing we want to do is distinguish between things that are considered to be non-electrolytes and those that are electrolytes. Keep in mind, most covalently bonded organic molecules are going to be considered to be non-electrolytes. They will not dissociate in a solution. Electrolytes, on the other hand, they will dissociate in a solution and form cations and anions. These substances have the ability to conduct electrical current when they are dissolved in an aqueous solution. All of our electrolytes have some unique function along with osmotic functions. Generally, when we look at the concentration, they are given as milliequivalent per liter, and that basically is electrical charges in a liter of solution. Now, we will be discussing a number of electrolytes, but the two that I want to put the most emphasis on are going to be sodium and potassium. We will be addressing a few other electrolytes, but the emphasis will be on sodium and potassium once again. The first that we are going to address is sodium. This accounts for 99% of the ions found in extracellular fluid and only accounts for a much smaller amount in the intracellular fluid. Now, this is a very significant gradient and is actually going to be maintained by the sodium-potassium pump. We want to keep in mind here that sodium is the primary cation or positively charged ion that we find in extracellular fluid, both the interstitial fluid and plasma. It is also the ion that exerts the greatest osmotic pressure. Now, when we talk about sodium balance, we do have a normal concentration of 135 to 145 milliequivalents per liter. Now, keep in mind, this is not something that you need to memorize. The general requirement of sodium on a daily basis is about 2 grams per day. Now, when we are talking about the typical North American, we generally do not have problems getting our sodium, and our biggest problem is usually having too much sodium in our diet. Now, this intake can vary quite a bit. Some people are not getting a lot of sodium, whereas I just addressed, most people have no problem getting sodium, and there are some people that are consuming really, really large amounts of sodium. The primary way in which we lose sodium will be through the urine, feces, and sweat. The amount of sodium that's lost in our urine is going to be regulated by hormones. Those hormones are aldosterone, ADH, and AMP, or atrial natriuretic peptide. Now, if we look at one of the primary roles of sodium, it is to maintain plasma solute concentration. So it is the most important electrolyte in determining blood plasma osmolarity and regulating fluid balance. The extracellular fluid is considered to be hypertonic if sodium level concentrations or sodium levels go up. Due to an increased sodium or a decrease in water content, water will move from other compartments into blood plasma until normal concentration is returned. The extracellular fluid is hypotonic if sodium concentration decreases, and this decrease could be due to decreased sodium or an increased water content, which actually dilutes the solute concentration. Water now moving from plasma into cells until normal concentration is reestablished. So note what we just addressed here. The concentration of sodium primarily determines whether or not we will be seeing water move from one compartment to the other. And remember, one of the things that we regulate very, very tightly is plasma solute concentration. Now, if we look at changes in plasma volume, the retention of sodium and water will actually cause an increase in blood volume and a corresponding increase in pressure because now we have more fluid in a closed system. Loss of sodium and water will result in the exact opposite. That is why individuals that have high blood pressure are often recommended to consume a diet low in salt. But one thing to remember when we are talking about high blood pressure, very few people are actually sodium sensitive. It is just a regular recommendation. Most people do not know what is the underlying cause of their high blood pressure. Now, when we look at sodium imbalances, they have a certain name. These are generally the most common type of electrolyte imbalances, and when sodium levels are above normal, it's known as hypernatremia. When sodium levels are below normal, that is hyponatremia. And what causes these to change the most is the actual water we consume or level of hydration. Now here, once again, we are coming back to that concept of balance. Ideally, sodium in is equal to sodium going out. And if we look at how we are losing sodium, it's illustrated here on the scales that it is typically lost in our urine, feces, and sweat. Now, there are a number of hormones that are regulating sodium concentration, and they impact sodium levels by either altering loss of both sodium and water in our urine. The first is aldosterone. This actually is a hormone that retains sodium and water, and it is responsible for maintaining sodium blood plasma concentration. ADH, this is a hormone that will retain water and decreases sodium blood plasma concentration. ANP, this actually is a hormone that increases excretion of sodium and water, so it will decrease sodium blood plasma concentration. Now here we're basically looking at what happens, when we have abnormalities in plasma solute concentration, and really it's sodium. Here we're looking what happens if we have decreased water or increased sodium concentration. Our plasma is now considered to be hypertonic, and there is an osmotic gradient here in which water will move from cells into plasma until equilibrium is reached. If we look at increased water or decreased sodium concentration, we now have a blood plasma which is considered to be hypotonic, and we will be reversing the movement of water. It will actually be moving out of the plasma and into the cells until we reach a normal plasma solute concentration. Now, the next electrolyte that we need to address is going to be potassium. Now, there is a big difference between sodium and potassium. Remember, sodium is our primary extracellular ion, and that makes potassium our primary intracellular fluid ion. And now, the concentration, once again, is going to be maintained by the sodium-potassium pump. Now, whereas sodium was the ion primarily responsible for maintaining osmotic pressure in extracellular fluid, potassium will be exerting that effect in intracellular fluid. And also, we need to remember that potassium is required for all neuromuscular activities, controlling heart rhythm, and plays a significant role when we talk about tissues that are excitable. Remember, when we're talking about excitable tissue and the generation of action potentials, the exit or efflux of potassium from the cell was always responsible for repolarization. Now, one thing to keep in mind here is when we're talking about potassium balance, the only part that's regulated is extracellular fluid. Now, this is an important thing to remember. And one of the reasons why this is the case, we have to go back to understanding why potassium and how potassium plays a role in establishing a negative membrane potential at rest. So this is due to the fact that there are actually leak channels for potassium. So remember, a leak channel is a channel that's always open all the time. So that ion will always move from high concentration to low concentration. So this is why we see potassium primarily leaving the cell. And also remember, it is normal concentration will be regulated by or kept normal by the sodium-potassium pump. Now, one thing to keep in mind when we are looking at electrolyte imbalances, potassium imbalances are considered to be the most lethal, and they can result in either cardiac or respiratory arrest. Now, if we look at total body potassium, it is going to be regulated by potassium intake and output. Now, keep in mind, the primary source of potassium are fruits and vegetables, and as North Americans, we probably have problems getting that and are not eating enough fruits and vegetables. The other thing to remember here is potassium is one of those ions that is not reabsorbed to a great degree when we talk about reabsorption. Now, The majority of potassium is lost in the urine, but this amount can actually fluctuate. Greater amounts of potassium will be lost if plasma levels are high, increased aldosterone secretion, and a high blood pH. When we look at potassium distribution, the ratio of potassium in intracellular fluid to extracellular fluid is dependent upon sodium-potassium pumps and the previously mentioned leak channels for potassium. Now, when we look at potassium shifts, potassium can be redistributed under the following conditions: changing blood plasma potassium concentration, changing the plasma level of hydrogen ion, or the presence of specific hormones found within the blood. Now, the change in blood plasma potassium concentration will cause shifts in potassium between extracellular and intracellular fluid. With increase in plasma levels of potassium, this is known as hyperkalemia, and potassium will move from the extracellular fluid into the intracellular fluid. With a decrease in plasma potassium levels, hypokalemia will be the case. So now potassium will move from the intracellular fluid to the extracellular fluid. Now, if we look at changes in hydrogen ion concentration, if there is an increased hydrogen ion in the extracellular fluid, now we're talking about in acidic condition, excess hydrogen ion moves into the intracellular fluid. Potassium moves out to maintain the electrochemical gradient, and it will move in the reverse direction if there is a decrease in extracellular fluid levels of hydrogen ion. Now, we also know that certain hormones, and we are going to use insulin as an example, can also induce shifts. Now, decreases in blood glucose and blood potassium will stimulate sodium-potassium pumps. This is going to increase the transport from the extracellular fluid into the intracellular fluid. And what this does primarily, it helps prevent elevated potassium levels or hyperkalemia that could potentially occur as potassium is absorbed following a meal. Now, here, once again, we're talking about potassium balance. The primary way in which we're going to lose potassium will be in our urine, feces, and sweat. Now, there are hormones that are regulating blood levels of potassium, and that is done by altering the loss of potassium in the urine. The primary hormone responsible for this is going to be aldosterone. Aldosterone causes the secretion of potassium by kidneys and excretion into the urine, so it actually will decrease plasma levels of potassium. Now here we have that diagram that talked about those other factors that will actually have an impact on the distribution of potassium. And the first thing that we're going to be looking at is what happens if blood potassium increases. In that situation, we can see here that potassium is entering the cell. If we happen to experience a decrease in blood levels of potassium, then potassium will actually exit the cells. It's also used to maintain pH. If there is an increase in hydrogen ion concentration, hydrogen ion enters the cell and potassium will exit the cell. If blood hydrogen ion concentration decreases, hydrogen now will exit the cell and potassium enters the cell. We also talked about what potentially happens to sodium levels when we consume a meal. Once we consume a meal, insulin will be released, and that is going to increase the movement of both glucose and potassium ion into the cells, and that prevents potassium levels from going up in our extracellular fluid. Now, we are going to speak about a couple of other ions. The first is going to be chloride ion. This is an ion that's associated with sodium. Remember, sodium chloride or table salt. And it's going to follow sodium due to electrostatic interactions. The amount lost in urine is going to be dependent upon plasma levels of sodium, and it is going to be regulated by the same mechanisms. Chloride is the most abundant anion that we expect to find in the extracellular fluid. We basically obtain it in our diet primarily as it's related to sodium chloride. It is going to be lost in sweat, stomach secretions, and urine. When you have an increased level of chloride, it is known as hyperchloremia. whereas a decrease in chloride levels will be known as hypochloremia. Now, if we have calcium, generally when we think about calcium, the first thing that we think about are our skeleton and our teeth. That is basically where we store calcium. What we really need to be more comfortable with are the actual roles of calcium with respect to physiology. It is going to be moved by pumps out of cells or into the sarcoplasmic reticulum. This actually, and also it prevents binding phosphate within cells and hardening. Calcium, remember, is needed for muscle contraction and the release of neurotransmitters. It actually serves as a second messenger and plays a role in the clotting of our blood. Generally, we obtain calcium from our diet, and it is going to be lost in our urine, feces, and sweat. Increased levels of calcium are known as hypercalcemia, whereas decreased blood levels of calcium are known as hypocalcemia. Now, we have phosphate, and phosphate is the most abundant negatively charged ion, or anion, we find in our intracellular fluid. 85% of this is found in bone and teeth as calcium phosphate. It is a component of DNA, RNA, and phospholipids. It is a very potent intracellular and urine buffer. And most ionized blood plasma, about 90%, is bound to proteins. And it's regulated by many of the same mechanisms that play a role in the regulation of calcium levels. Another anion is magnesium. This is primarily found in bone or inside of our cells. It is the second most abundant cation that we find in our intracellular fluid. It participates in very many enzymatic reactions. It assists with the sodium-potassium pump, plays a very important role when we're talking about the relaxation of muscle, and we're going to obtain it from beans, peas, and leafy green vegetables. It is primarily lost from blood and sweat and urine, and the concentration of magnesium is regulated through the kidney.